Greetings. I'm Ellen Treppe from the Office of Alumni Relations at Thomas Jefferson University, and I'm happy to welcome you to today's Q&A. Thank you to everyone who submitted a question prior to today's talk. I've done my best to synthesize all your questions so that we can cover a lot of ground today. But keep in mind that I might not pose your questions in the exact way that you submitted them. Should we have time at the end of the program, we'll open the chat to take more questions. But now I am pleased to introduce Dr. John Zurlo, Chair of the Jefferson Enterprise COVID-19 Task Force and Chief of Infectious Diseases for Jefferson Health. He also serves as the W. Paul and Ida Havens Professor of Infectious Diseases at the Sidney Kimmel Medical College at Thomas Jefferson University. Dr. Zurlo, thank you so much for your time today. The floor is yours.
Thanks for having me. I'm just going to share my screen. And I hope everybody can see that. I think we can. Good. Yeah. So again, thanks for having me. All I've been doing, and really in the last year and a half, has been COVID. And I guess obviously it's on everyone's mind. There always seem to be new changes and new chapters. I call this particular chapter Chapter D, or Delta, as we've seen the Delta variant really causing now more problems with COVID. If for those in the audience who remember from the 80s, this was an ad for an airline of the same name, and so this was an interesting cartoon, I thought. So what I'd like to talk about today, and I'll try and keep my comments brief so as to allow for questions and so forth. I'll talk a bit about where we are with the epidemiology of COVID, both nationwide, a bit worldwide, and of course in Jefferson, as well as where we stand with Delta. I'll talk a lot about vaccination, both the rates, its effectiveness, especially against Delta. We'll talk a bit about the correlates of immunity. How do we determine that someone's developed immunity to COVID? And then talk about an ever important topic now, vaccine boosters, and a little bit about emerging treatments for COVID. So a bit about the epidemiology. Frankly, one of my best sources has been the New York Times. I have a feeling many in the audience look to the Times and other publications to get their latest COVID information. But as of yesterday, you can see where we stand with cases in the United States. We've seen, of course, the initial rise in cases back last year in 2020, the big surge we had in the winter, and now this developing surge that we're seeing across the country. We're seeing now, as of yesterday, a 14-day average of 29% increase in cases of COVID nationwide. And these are, of course, the COVID hotspots. And as everyone's been well aware, most of the real hotspots for COVID have been really in the South and to some degree in the West. Here where we are in the Northeast and in the upper Midwest, we've seen sort of a less of a dramatic picture of cases. And you've seen this slide of COVID cases by region, with the blue line being the South. This has really been the worst problem. And you can see the West, the Midwest, and here in the East Coast where we are in the Northeast. And you can see a particular outlier of Mississippi, where we've seen a dramatic increase in cases. You can also see now a matching map showing COVID hospitalizations. And again, similar to the caseload, we're seeing the greatest percentage and greatest concentration of hospitalizations in the South. Florida, Mississippi, Alabama, Louisiana, these have all been in the news because the hospitals are really overwhelmed right now. You can see once again in the Northeast and some of the rest of the country, we're not seeing as bad a problem in terms of hospitalizations. And you can see, not surprisingly, just a hint, as we'll be talking about this in the future, you can see this slide showing the vaccine effectiveness as well for hospitalization. And you can see on the one side, on the y-axis, you can see the hospitalization rate, and on the x-axis, you can see the vaccination rate. And there's a pretty good correlation between the level of vaccination in a community and the level of hospitalization. CDC estimates that something like 97% of hospitalizations are among unvaccinated individuals. And there's just ample developing data to support that conclusion. This is where we are in New Jersey and Pennsylvania. We've seen increases here in New Jersey, for example. We've seen a 53% increase in cases, and in addition in Pennsylvania. And these are the heat maps showing where the cases are, quite frankly. So again, we have not here in our region escaped the rise due to the Delta surge. This is where I am in Philadelphia County, and we're seeing now increase in numbers of cases, though not as dramatically as has been seen in these other very hotspot parts of the country. Just show you an interesting slide looking at admissions by month based on age group. And as you can see, back here is January through July, and we're seeing a decrease in the percentage of individuals who were 75 and over, a decrease in 65 to 74, and corresponding increases in hospitalizations in younger age groups, especially in the 25 to 44 year age range. And this may be, at least in part, due to Delta. Delta, we certainly know, is more transmissible, but it may indeed also cause more severe disease, perhaps just because of the level of transmissibility and the high viral loads achieved with Delta compared to previous variants and previous parts of the pandemic. So I'll just bring everybody up to speed on variants and what they are. This slide shows the CDC genome sequencing. They started to do genome sequencing on all of these viral isolates, and really in earnest since the beginning of the year. And though they all had names like B117 and B1617.2, the reality is we tried to simplify that and really use these Greek letters, alpha, beta, gamma, and so forth and so on. I think what's important to understand about the variants is that the variants of interest, of real concern, contain variations in the genome that encode for this so-called spike protein. The spike protein is that part of the virus that attaches to the epithelial cells, and in particular to the lung cells, that ultimately lead to entrance of the virus and then replication and so forth and so on. So these different variants have different levels of genetic variation that give an advantage to these viral variants in terms of their are the so-called alpha variant that really developed or was described in the United Kingdom. And what you can see is that over time, this particular variant has petered out. And really, over the last probably month or 2 months, we see nothing but, virtually nothing but Delta. You can see in this last week, 8/14/21, we're seeing almost entirely all of this orange and dark orange genome sequencing is Delta. So Delta has taken over virtually everywhere, certainly in the United States and in much of the world. Just to show you this genome sequencing here at Jefferson, we had 328 isolates that we genome sequenced between mid-February and late June, and only 3 of them were Delta. We first saw a Delta in late April. From June 23rd to July 24th, there were 82% were Delta, including the last 20 specimens consecutively. And of the 15 isolates we've done from August 3rd to the 9th, 100% Delta. So we're seeing exactly here in Philadelphia what is being seen throughout the country. So let me talk a little bit about COVID vaccination. Just to show you where we are with vaccination, this slide shows the United States vaccination of individuals receiving at least 1 dose and those fully vaccinated for various ages. So in the entire population, just over 50% have been fully vaccinated. Of the individuals 18 years and above, 63% have been fully vaccinated. And for those 65 and over, 81% have been vaccinated, which is excellent. As you see in the other side of the slide, we saw this massive increase in vaccinations, sometimes to more than 4 million doses a day, that peaked sometime in April and then declined down to low numbers in early July, but lately now we've been seeing a rise in the number of vaccinations. And I think and this is well before the Pfizer vaccine was now fully approved. And now we're vaccinating in excess of 1 million a day. So we have been gaining a bit of ground in terms of vaccination. I'll show you a little bit about Philadelphia vaccination. Here in the city, we vaccinated nearly 80% with at least one dose of vaccine, and we're fully vaccinated for nearly 65% of our adult population. And what you can see here is the vaccination rate for various age groups and race ethnicity. And as you can see, the outlier here in the 18 to 44-year-old are African Americans. You can see in all categories that Asians are the highest vaccinees of all age groups. And what we've interestingly seen, while early on in the vaccine process, Latinos were under-vaccinated, but they've really soared both in the younger age groups as well as all of the other age groups. And what we can see is that in the 45 to 64 and 65 to 74, it's really the white population that's lagging. And here in the older population, we can see that white and African American are on the lower end. So we have a lot of work to do in trying to convince individuals to get vaccinated. Of note, as of yesterday, a total of 163,000 and change individuals in Philadelphia have tested positive. So when you add that number to the number of individuals who are vaccinated, and of course there is overlap because many individuals who have had COVID have been vaccinated, we're at a level of overall immunity that's at least approaching a level that we would hope to be herd immunity. As we've seen about the effectiveness of vaccination, the CDC has a site where they follow all individuals hospitalized, or as many as they can be reported, hospitalized who've been vaccinated. So just to give you some figures, as of 8/16/21, of over 168 million people fully vaccinated, they've recorded about 9,700 individuals with serious COVID infections who've been reported to the CDC. I want to emphasize that we don't have full reporting of all of this, but these are the best data that we have. And you can see about half of them, or slightly less than half, are female. And this shows both the deaths as well as hospitalized but non-fatal. And you can see that most of the individuals who have died have been over the age of 65. Most hospitalized have been over the age of 65, but you can see that many of these individuals who are hospitalized who have died have either been asymptomatic or have not, or their hospitalizations and deaths have not been related to COVID. So this is one piece of data that we have about vaccine effectiveness. As far as vaccine effectiveness against Delta, I'll show you a little bit of data. Now, everybody's aware of this this outbreak that occurred in Cape Cod in Provincetown, Barnstable County, that was reported by the CDC at the end of July. That was rather disturbing. There were 469 cases associated with, quote, summer events in Provincetown. 346, or nearly 3/4 of cases, were diagnosed in fully vaccinated individuals, mostly Pfizer and Moderna, the mRNA vaccines. And you can see that the genomic sequencing for those that were sequenced, not surprisingly, were 90% Delta. And interestingly, 274, or 79%, were symptomatic. So these were not just asymptomatic from testing, they were in fact symptomatic. On the positive side, only 4 were hospitalized, and there were no deaths among the vaccinated individuals who contracted COVID. As they described the event, quote, this is from the New York Times, restaurants were booked solid and snaking lines formed outside dance clubs. There were conga lines, drag brunches, and a pervasive, joyous sense of relief. Because if you remember at that time, as cases were dropping through May, June, and early July, we really thought that with vaccination that we were past COVID finally. The CDC, if you recall, in early May, had given now new guidance about what vaccinated individuals can do compared to unvaccinated individuals. So really, there were just a lot of people together having a great time. We were all, and myself included, were just thinking about what we're really finally behind COVID. I was prepared to sort of move into the other things that I'm supposed to do here in my job. And then obviously the Delta variant hit and we're back in the thick of things. The average age of these individuals is somewhere between 30 and 35 years old. And this shows the sort of a slide as cases develop. The light blue is fully vaccinated, the dark blue is unvaccinated. And remember, the vast majority of people at this event were in fact vaccinated. So therefore, it's not surprising to see that most cases were among vaccinated individuals. Some of the conclusions now, we've seen a super spreader event among highly vaccinated individuals, but we have to keep in mind the denominator. As population level vaccination increases, we will clearly see more cases among vaccinated individuals. That's certainly true. On the other hand, there could have been many asymptomatic infections because we typically would not necessarily test individuals who maybe had an exposure, but what never became symptomatic. And we have to consider clusters. Each cluster is going to be unique and may include individuals, for example, who are immunocompromised. But again, in this particular incident in Provincetown, these people were in very close quarters for extended periods of time. Apparently the weather that weekend was very rainy, so this was largely many people crowded into indoor spaces. So I'll show you a little bit about the accumulating data regarding the effectiveness of vaccination against Delta. Just within the last 10 days, there have been multiple publications from CDC. There have been data from Israel, as probably many people have been aware of, that really are pointing to the same kinds of things. So I can't present each of all of those studies because it would just take too much time, but I'll present some key data. And this study, this came out from, published just yesterday in the MMWR, COVID cases and hospitalizations among adult by vaccination status in LA County. And this looked at a period of May 1st, just as Delta was probably arriving, to July 25th, when Delta really was in full force. And I'm going to show you just one slide from this publication. And this is really just an age-adjusted 7-day rolling both infection and hospitalization rate by vaccination status in LA County during this period. And you can see the top figure shows the age-adjusted just infection rate. These are cases of COVID. And you can see the number of cases over this particular time. The black dotted line is the cases that were diagnosed among unvaccinated. You can see that takes off rather significantly. And among either fully or partially vaccinated, it's much, much reduced. But more importantly, and this is a common story, we're looking at age-adjusted hospitalization rates. And you can see over the same period of time, unvaccinated in hospitalizations are very, very high compared to those who have been partially vaccinated or fully vaccinated. And now we're seeing report after report after report that confirms what CDC has been saying, which is now the hospitalizations that we see are almost entirely among unvaccinated individuals. So I'll try and conclude by providing kind of some important statements about vaccine efficacy now in Delta. National and local data suggest that vaccines remain very effective. Are they as effective as what we saw back in December when the Pfizer and Moderna data were first released? Remember, they said something in the range of 94 to 95% effective in reducing the chances of symptomatic COVID. We're now seeing reduced numbers. And without going into great detail to sort of put together all of the data, it appears as though that the vaccines are now less effective, perhaps in the range of 50, 60% in reducing the chances of symptomatic COVID. And of course, the question that that is at the center of all this. Are the vaccines less effective because of waning immunity, or are the vaccines less effective because of the rise of Delta? And that's the question that we're trying to answer. The vaccination rate has increased to over 1 million per day as Delta-related infections have surged. Vaccinated individuals can spread COVID, but without presenting any data, because I don't have a lot of real data to present, people are likely less to be infectious for a shorter period of time if they've been vaccinated. For Delta, it's likely that vaccines are not as effective in fully preventing infection. And again, the question, is it waning immunity or reduced effectiveness, or both? I'm going to go out on a limb and say that it's probably both, but probably more related to Delta. Yet, there are consistent reports that all approved vaccines are highly effective in preventing severe disease that results in hospitalization and death. And that has been now a constant in all of the data. There have been data now regarding the effect of booster vaccinations, which were initiated in Israel. Now, if you remember, Israel is a highly vaccinated country, almost entirely with the Pfizer vaccine. There were a surge of cases beginning in late June, again, virtually entirely due to Delta. And so Israel began offering booster vaccination doses to individuals over the age of 60 on July 30th. And then even later, as recently as August 19th, they began boosters for individuals 30 and older, but only those whose second dose was given at least 5 months earlier. And these data are from a news feed, which is where I'm getting so much of our COVID data, because this has not yet been published. And what this shows is a rate, and I'm not sure what this number means on the y-axis, but we're seeing unvaccinated individuals 60 and over. Unvaccinated simply means that they've not gotten their booster. It's the red line that we want to focus on, because these are individuals 60 and over who've gotten a booster dose. And you can see that that number, the infection rate in that has dropped rather precipitously. Again, I've not seen this published. This is, the source was the Israel Institute of Technology and Israeli Health Ministry data. This is the first data that I've seen that not only is there a theoretical reason why boosters will work. In fact, we've seen now data to support the actual efficacy of booster doses of vaccination. The next and almost last part of my presentation has to do with the correlates of immunity to viral infections in general. So we know that for certain viral infections, and I've given some examples, measles, varicella, which is chickenpox, and rubella, German measles, we know over many, many years of experience that certain means of doing antibody titers, measuring them, and certain levels of antibody titer, they correlate with true immunity to further infection. We know other viruses like mumps and rotavirus, we simply don't have a good correlate for immunity. And we have viruses where if you measure antibodies, they clearly correlate with immunity when measured early. But as time goes on, for example, with hepatitis B, the levels of antibody that we measure often come to a point where you can't measure them anymore, yet we know that individuals remain immune to infection. Hepatitis B is a great example. What are the correlates of immunity to COVID? And the answer is we don't know. There are antibody tests that are available, and they've been available since last year. Right now here at Jefferson, you can get a panel that includes antibody to the spike protein, which would be positive for individuals theoretically who've been vaccinated or who have had COVID, or both, and then antibodies to nucleocapsid protein, which could only develop for people who have been infected with COVID. We can measure them, and it kind of gives us a warm feeling for those who have had these tests that, yeah, I have antibodies. But the fact is we don't know what level of antibody or what particular titer of or what particular methodology truly correlates with immunity. if you think about it, if we had that information, then we could more rapidly increase our ability to study vaccinations. If, after all, if you can just simply measure an antibody at 2 or 4 or 6 weeks after a vaccination and say, yeah, we know that correlates with long-term immunity, then we'd be in golden shape. But the reality is we don't have that right now. At the moment, there are no guidance. There is no guidance about measuring these antibodies to determine if individuals are immune, even though many individuals do have these tests done. So this is an important measure that we're waiting for. And I suspect that we will ultimately, in the very near future, we will have such a measure. But right now, we simply don't have that. I'll make another point, which is, if you remember, in the development of these vaccines, we had to do it quickly. I mean, as of in 2020, COVID was upon us quickly. We had to develop vaccines quickly, and we were very successful in doing so. Remember, most vaccines take a minimum of 4 to 5 years to develop. And part of that time is trying to understand both the appropriate dose and the optimal schedule of vaccination. Back to hepatitis B, we give hepatitis B at 0, 1, and 6 months, and we find that to be very effective. Perhaps, had we the time, we would have learned that COVID vaccination should be at time of 0 and maybe 3 months, or 0, 3, and 6 months. We simply had to rush these quickly. We may find that with a booster dose, even a single booster dose, that may provide lifelong immunity, as we see with hepatitis B. We simply don't know that yet. So really the final or near final part has to do with boosters, because that's a hot question right now. Once again, we don't have measures of immunity such as spike protein antibodies. We don't know that they're neutralizing. You could consider boosters for several circumstances. One for immunocompromised hosts. And as you've seen in the last few weeks now, we have now an authorization to offer a booster vaccine for individuals with certain immunocompromising conditions. We might consider them for individuals who are older, because we know that certain vaccines, that immunity is not as strong and not as durable in elderly populations. Influenza vaccine would be a great example. We could consider it for individuals, all of the individuals with waning immunity, irrespective of their age. And then, of course, the final question is, do we need additional boosters or even redesigned booster vaccinations for variants like the Delta variant? Those are all the rationales. At the moment, as I discussed earlier, there is no clear guidance on antibody measurement following vaccination. So boosters, again, now approved for immunocompromised individuals. And at least as of a press release, we're to begin offering vaccination booster doses around the 20th of September for individuals who've completed vaccination at least 8 months ago. And right now, what's been suggested is that it will initially be healthcare workers, perhaps individuals who live in congregate care settings, many of whom are older, and individuals over a certain age, perhaps age of 60. But we've not seen any hard data about this. But I do believe somewhere in September, we will begin offering vaccinations or booster vaccinations to the population at large. But I'm not sure exactly who will be candidates for that. And again, looking at the Israeli data, there's at least some data now that we've seen that they actually work. The last slide I'll present is simply emerging treatments. We've kind of forgotten all about how do we treat COVID. And I'll say that we have lots of different agents that remain in the pipeline, and I'll just list them here. Probably molnupiravir has gotten a lot of press as being potentially effective. There's a drug called favipiravir, which we and many other institutions have been slow to bring to clinical testing. But the real challenge is, can we get to patients soon enough? I've been dealing with COVID for the last year and a half, and the real challenge we face is that when people show up at the hospital, we certainly have a 40-page document of how to treat them. There are things you've heard of, monoclonal antibodies, remdesivir, dexamethasone, tocilizumab, baricitinib, all of these fancy names of drugs that we use, and that we have data that would suggest, yeah, they work okay. They can reduce the hospitalizations, reduce the rate of people getting really sick with COVID, reduce the death rate, but not dramatically so. I wish we had a dramatic treatment for COVID. Quite frankly, the most dramatic treatment we have for COVID right now is vaccination. I want to emphasize that point over and over again. I'm just concerned that for those individuals who are destined to really accelerate and develop the pneumonia and all of the critical illness that occurs, I'm just concerned that the pathway to that sort of immunopathogenesis occurs very quickly. And I'm just always concerned that we're behind the 8 ball when these patients present. How can we get them diagnosed soon enough and into treatment soon enough remains the question. So that's the last of my slides, and I guess we'll hopefully be able to answer as many questions as possible. So thank you very much.
Thank you so much, Dr. Zurlo, and thanks to all of our attendees today who submitted questions ahead of time. And your presentation was so thorough that a lot of them were covered, so we'll be able to sort of keep going. So one question that I have is, let's say I go and get a COVID test and they send my nose swab to the lab. Are they, other than knowing whether or not I have COVID, are they actually testing for the particular variant, or how do we test for a variant? How are these things being studied?
Yeah, there's no systematic way that variants are being studied. Just doing the genomic sequencing to determine variants is somewhat complicated and expensive. So back as early or as recently as early June, when we had very few cases, we were doing genomic sequencing on virtually every specimen. Now we have to just do a sampling of them. And I think that's true throughout the country. We're working toward a more systematic approach to that, but not every viral isolate that's tested is tested for whether it's a variant, which variant it is actually, yeah.
And speaking of which variant, one question that people had is, we've been hearing so much about Delta. Are there other variants that scientists are keeping tabs on, or that you're sort of particularly watching?
Right now, as I know it, the CDC is watching a total of about 11 variants. Which variants do they watch? They watch those variants in particular that show changes to the spike protein that could alter their infectivity and transmissibility. So not all of the variants end up turning out to be dangerous. So for example, the P1, I think that was the Gamma variant that really overtook Brazil. We saw early on in the pandemic, or rather early on this year, it turned out to be, 5 or 10%. And we've seen that number gradually decrease and diminish. So not every variant, even though it can cause significant outbreaks, can successfully compete with other variants. So I think we'd have to agree that the Delta variant has been extremely effective in its ability to compete. And so whether any of these other variants, we've heard of Lambda, for example, whether they'll be able to compete remains to be seen. But maybe the most encouraging thing is, there's only a limitation to a limit to how effective these variants can become. There's only a certain number of changes of amino acids and so forth that will end up being effective. And the reality is, unlike a year and a half ago, when the virus, whichever variant, was really attacking a completely immunologically naive population, meaning human beings, now there's considerable partial or maybe full immunity. So that's the encouraging part as we see which of these variants take off.
So moving on from variants, it's all interrelated, but as you might imagine, a lot of people had questions about breakthrough infections. And so, one person asked, if a fully vaccinated person tests positive for COVID, how long should they quarantine?
Yeah, that's a good question. The CDC suggests that on the typical patient, this is well before COVID or vaccination, that an individual should stay quarantined. The typical period would be 10 days. For somebody who develops symptoms, from the time of their symptom onset to about 10 days, provided that at that day 10, they're no longer febrile, they're improving. So that's what we typically say. For immunocompromised individuals or for individuals in the hospital who are in intensive care, we extend that to 20 days, but we don't really know that for sure. I think it's more logical to think about that in immunocompromised than in critically ill, but that's where we're saying. For individuals who get tested who are asymptomatic, we simply wait 10 days. That's what we say.
Wonderful. And if a vaccinated person does have a breakthrough case, can they expect maybe a super immunity thereafter since they've been vaccinated and have had COVID?
I don't know the answer to that. I don't think we have any data to speak to it, but I would have to think that the combination of vaccine and a Delta infection will provide significant immunity to future infection.
So, football season is upon us and people have been eager to gather and get together. And so what recommendations do you have for people who want to attend large scale events, either inside or outside? What would you say to folks about that?
Okay, number 1, number 2, and number 3 are get fully vaccinated. So let's start there. And as time is going on, if you're immunocompromised or if you're in an age group, as we devise this for booster vaccination, get your booster. So that's number 1. First, again, 1, 2, and 3. Remember, the most important challenge would be indoor spaces with lots of people and poor ventilation. That's the most the riskiest kind of situation to be in. So I think especially in those situations, I think in any indoor situation at this moment in time, for fully vaccinated people, you should wear masks indoors. Outdoors have always been a much safer venue. Now, perhaps in really close quarters, when there is really kind of a hot day without much wind, it would probably behoove people in a stadium or something to wear a mask. That would be my general guidance on how to pursue it. In a much more open area, lots of air circulation outdoors, I think the risks, especially among vaccinated people, are probably quite low.
Would you have different recommendations for, say, smaller gatherings of people indoors, outdoors?
Yeah, I think the recommendation still would be for small gatherings, dinner parties, home gatherings, when everyone is vaccinated. I think those are still safe things to do. I've been doing it, and my guess is much of the audience has already been doing it.
Wonderful. And one question that I found sort of interesting that we got was, do you think the risk of air travel has increased now that Delta is sort of living among us?
Insofar that there are a lot of people crowded into indoor spaces, especially at airports, in terminals and all that kind of stuff. I have to believe that it's a little more challenging now than it was, say, 2 months ago. Gets still back to the same issue of masking and full vaccination,
Mm-hmm.
So is it safe to travel? Under those circumstances, I'd say, yeah, I think so. That would be my take.
Wonderful. So one last breakthrough, sort of within the breakthrough category question. So did the CDC stop collecting statistics on non-hospitalized breakthrough infections? And if so, do you think this has impacted vaccine hesitancy?
It would be great if we could really get a full, consistent report of all breakthrough infections among vaccinated individuals. There have been estimates both by the Kaiser Health Foundation as well as CDC, but they are truly estimates. It's really very difficult to get that information, unfortunately, at the moment. So yeah, I'd love the information, but it's not going to be easily available.
Mm-hmm. So moving on to booster shots, and a lot of people had questions about the timing of the booster shots, which I think you did a wonderful job of covering. But I know that a lot of our healthcare professionals who are on with us today are starting to get worried about the fact that they're 7 to 8 months post first vaccination. But it sounds like that's maybe coming for them.
Yeah, I mean, again, the White House suggested the 20th of September. And so I get questions every single day, especially among older faculty who are very concerned. And so it is coming soon. And I think the good things about it, or the things that are encouraging about it, compared to when we began vaccination back last December and January, starting with healthcare workers, among others. Remember, one of the challenges is we faced limited vaccine supply. Right now, there's plenty of vaccine. And so, and really the question I think also is, will all healthcare workers be required to get it? I'm not sure about that. Do all healthcare workers really truly need it? I don't know that part either, but I think certainly all healthcare workers will be offered vaccination. And I think the priority should be among older healthcare workers, certainly healthcare workers who have immunocompromising conditions, and perhaps those who have medical conditions that have really caused more trouble with COVID, diabetes and heart disease and so forth and so on. So this is, we're still writing this story and these recommendations as we move along. So it won't be long is the bottom line.
And since we're talking about boosters, what are your thoughts on mixing boosters? So, I got Moderna. Should I try to get a Pfizer or J&J when it's my turn for a booster, or should we stick with what we had?
Yeah, right now the CDC for the immunocompromised individuals has guidance for boosters for only Pfizer and Moderna. We don't quite know what to do with the J&J. There have been certainly studies published of mixing, suggesting even that, using a different vaccine for the second dose, I don't know about the third dose, may provide some advantage. We don't know that yet. So the current guidance, at least for immunocompromised individuals, and my guess is for all individuals, will be get the same vaccination that you had. But if it's a time that an individual doesn't know what they were vaccinated with or can't get the vaccine that they had, then they should simply get the vaccine at hand, at least either the Moderna or Pfizer. Again, we're a little bit uncertain about what to do with J&J, but I suspect we're going to see further guidance about that in the weeks to come.
Great. And so what about the timing of COVID vaccinations, say with flu vaccinations or other vaccinations, or now with COVID boosters? Are there recommendations for timing of those things?
At the start, the CDC had suggested that COVID vaccination should not be given within 2 weeks of any other vaccine, but they've changed that. There's no reason then at this moment to delay other vaccinations. So, for example, people can get, a COVID booster and an influenza vaccine in the same sitting, for example. So there's no guidance, there's no restrictions now.
Great. So what about the effect of other drugs such as Rituxan on vaccine efficacy? Are there any considerations for healthcare professionals?
Well, I don't think we fully define that. We certainly know that that various immunosuppressive medications, best examples, because we've studied it more carefully, it has to do with transplant patients who are on drugs like cyclosporine, for example. And we know these individuals don't respond as well. I don't know that I can answer for every single drug. And that's the challenge, is that, again, there's a population like transplant patients who are highly studied in comparison to there's so many individuals with so many different immunocompromising conditions. So it's hard to answer. My take is, when in doubt, get a booster. I think it makes a lot of sense.
Great. And then can you talk about the fatality and stroke incidence of post-COVID vaccination compared with other vaccines like influenza?
The stroke, the whole stroke issue and the thrombocytopenia and thrombosis issue really has only affected the adenovirus vaccines, Johnson & Johnson and AstraZeneca. Not aware of any cases among the mRNA vaccines. And even among the AstraZeneca and Johnson vaccines, they are an uncommon event, mostly, but not entirely, in young people, sort of 18 to 45, mostly female, but not entirely, So I wish it were such a
Mhm.
narrow category so we can say this group of people should not get it, but it's affected a lot of different people. So we've not seen that with mRNA vaccines.
So shifting gears just a little bit, it's so for the longest time, the common sentiment was that kids aren't really at risk from complex complications from COVID. But now that we're living with the virus, is that the reality?
Well, we've seen, as probably everybody has seen in the news headlines, we've seen, particularly in the South, where we're seeing so many hospitalizations, we're seeing now more children and young adults than we had seen in the early part of the pandemic. So the question, of course, and again, to reiterate the same issue over and over again, it's typically unvaccinated people. And of course, for children under the age of 12, we can't vaccinate them, and that's a challenge. I have a feeling, by the way, we will get approval of one or more vaccines for children probably sometime in the fall, but I don't know that for sure. Um, is the reason we're seeing it more in children because of Delta? Is Delta more virulent? And that well may be the case. So we worry about children, and I know now my children are older, they're out of the house, so I don't have to worry about it, but I have a lot of my faculty who have young children at home, and everybody's in a quandary of what to do, how to manage that. What if their child gets sick? And so it's a really hard issue to negotiate.
Mhm.
And of course, there's this national, I'm going to say debate, but I just don't understand the debate part about it of masking children in school and so forth to keep them healthy and keep them from getting infected. Don't quite understand why there is a debate, but there is a debate. And I think we have to use all the tools we can to protect our children and protect, obviously, the vulnerable who live with our children. I think that's the challenge.
Mhm. Mhm. So this question is a little more in the weeds, but it feels very important to me. So I'm going to ask it in hopes that you'll be able to offer some guidance. So we had an anesthesiologist who works in a pediatric dental practice where she provides, or she or he provides MAC sedation. Is there anything that physician needs to consider?
Well, we have guidance that really hasn't changed very much for individuals who are undergoing some kind of aerosol generating procedure. And so certainly things have changed a little bit with vaccination. We tried to loosen things up a little bit, but now we're making things more stringent. Remember, in circumstances where people are at risk with aerosol generating procedures, we would typically recommend both a face shield and an N95 mask into those circumstances. And remember, for any of our healthcare workers who are simply uncomfortable in these kinds of situations, then we give them the option. You can wear an N95 mask as well as a face shield. We think those are very effective in preventing infection, maybe from somebody who's in a pre-symptomatic phase of infection, for example.
So we had a number of questions about antibodies today. So for those of us who are, sort of not healthcare professionals, what is there a difference between the antibodies that we develop as the result of having COVID versus the antibodies that we develop versus vaccination?
Broadly speaking, among the antibodies we can measure, again, we have just two classes that are at least commonly available. These are the nucleocapsid protein antibodies that can only occur when people who've had COVID. And then we have these spike protein antibodies that can develop either from natural infection, from vaccination, or from both. This is the challenge, though, is that we have not standardized this. And so in theory, if you develop spike protein antibodies after a vaccination, we would like it to mean that means we're vaccinated and we're protected, but we don't have that data yet. It's not standardized. We don't know what titer would be protective. Remember, we're not even getting a titer. These are arbitrary units. So it looks so tantalizing that, gee, you get tested, you're positive, it must be you're protected, but we don't know that. And therefore, we don't have any kind of broad recommendation about using antibodies to determine immunity from vaccination or from infection. But I think that's a very rapidly developing story. And I suspect we will have some kind of standardization of that in the very near future.
Great. And so I'm sorry if you've answered this a million times, but I'm trying to wrap my brain around it. Is natural immunity enough to protect someone from getting the virus again, or should they still get vaccinated?
Great question. We have relatively limited information to answer all of that question, but we have data last year, a large epidemiologic study from Denmark looking at the effectiveness of previous infection with COVID in preventing future infection with COVID. And their number, just back of the envelope, was something in the range of around 80%. And I think that's generally been seen, that for people who've been infected, their infection rate most certainly is much lower than if you've not been infected in the past. How does that now relate to Delta? Will previous infection, say last July, now it's Delta, do you have some level of protection? My guess is yes, but the level of protection is difficult to know. The only data that we've seen so far about vaccination for those who've been infected comes from Kentucky. It was from an MMWR study within the last 6 weeks. And they suggested that the data suggested very strongly that the combination of previous infection as well as vaccination provided additional protection against future infection. So we are advising all of our individuals, for example, at our healthcare workers, but I think for the entire population, if you've had COVID, yeah, you probably have some protection, but you'll even be better protected by vaccination.
Great. Let's see. So, just sort of as we're, running towards the end of our time together, so there was some folks had some questions about the persistence of COVID. So do you think this virus will be endemic with indefinite vaccination, or do we have a scientific estimation of when this virus might not be such a threat to us?
I don't know what the estimation of time will be, but it will most certainly end. For all the audience who's still there, this will end at some point. And I think it's going to end sooner than later. It just depends on what your definition of sooner. We'd all like sooner to be next week, but it's probably a little bit optimistic to think that's going to happen. With each wave and surge of infection, with more and more people getting infected and vaccinated, at some point we will reach a level where we'll see surges that are small surges, very localized, and so forth. And I would guess that that's going to occur really beginning over the next many months, not years. And so, I mean, that would be what we would expect of any newly emerging infection really to occur. That would be my take.
Wonderful. Well, so that sort of gets us to the end of our questions that came in before. And not to put you on the spot, since you've been on the spot for the whole almost hour, but any parting words that you would give to all of us as we sort of, live with Delta, protect our family, protect our friends, perhaps talk to our, as a Southerner, talk to our family and friends about how to be safe and to do the things that we need to do.
Yeah, and I just wanted, I am hoping people can remain optimistic. I've tried to continue an optimistic outlook and tone throughout this whole thing. As I deal with many challenges in my life, and we all do, I say to myself every morning when I get up, just got to deal with it. You just have to deal with it. So let's just keep moving on. We know what the solutions can be. Right now, until we reach a point where we're beyond pandemic and into endemic, we know the measures that work: vaccination, masking, social distancing. I mean, over and over again, we see the same things. I think trying to convince individuals who are resistant to these things is a challenge for all of us. And so we have to do the best we can in that regard. I mean, we're all in this together. So anyway, I remain optimistic.
Dr. Zurlo, thank you so much. The fact that you gave us your time to do this today, we so very appreciate it. And to all of you who joined us today, thank you for taking some time out of your day to be here with us. We hope that you will join us again for another alumni relations program, all of which can be found on our website. So thank you, everyone. Thank you, Dr. Zurlo, and I hope you all have a wonderful day. Stay safe.
Right.